Dr. Mitesh, please start.
Yes, sir. Hello, good evening, everyone, and warm welcome from IAP Allergy and Applied Immunology chapter. I am Dr. Mitesh Kakkad, a pediatric allergy specialist from Ahmedabad, Gujarat. Myself and Dr. Prabhat Nangia will be your host for the day. Dr. Prabhat Nangia is a trained cornea fellow from Sankar Netralaya, a gold medalist in FAICO pediatric ophthalmology and strabismus. He is currently working as a consultant cornea, ocular surface and cataract specialist at Suraj Institute, Nagpur. Welcome, Dr. Nangia. So today is a historical day in the history of allergy science as we embark our journey towards this unique educational initiative on eye allergy in collaboration with All India Ophthalmology Society for the first time. So let me first invite our allergy chapter chairperson, a dynamic personality and visionary leader, Dr. Neeraj Gupta, who initiated this concept. So for this welcome address, Dr. Neeraj Gupta.
Thank you, Dr. Mitesh, for the nice words. So, respected faculties, esteemed colleagues, and dear friends, it gives me immense pleasure to welcome you all for the launch of our webinar series today on eye allergy, a unique academic initiative jointly organized by IAP Allergy and Applied Immunology chapter and the All India Ophthalmological Society AIOS. Ocular allergies are often underestimated, yet they remain one of the most common and distressing allergic conditions in both children and adults. From simple seasonal conjunctivitis to severe vision-threatening allergic eye diseases, these conditions affect not eyes, but also the quality of life, school performance, productivity, and emotional well-being of our patients. Unfortunately, they are often underdiagnosed or managed in silos, either by ophthalmologists or the other. This webinar series is a step forward in bridging that gap. For the very first time, two national societies, IAP Allergy and Applied and AIOS, are coming together on one form with a shared vision to build awareness, share evidence-based practices, and develop a collaborative approach to the diagnosis and management of ocular allergies. Such a joint effort is not just symbolic but highly meaningful as it ensures that our patients receive holistic care that combines expertise from both specialties. Over the coming days, you will hear from some of the finest experts who will cover the spectrum of eye allergies, from clinical presentation and diagnostic strategies to the latest therapeutic options. This series is designed not only to update your knowledge, but also to empower you with practical skills that you take back to your clinics and hospitals. We are also going to release a eye allergy awareness flyer in both English and Hindi today during this webinar. I sincerely thank our colleagues from AIOS for joining hands to us in this historic collaboration. Together, we are setting the foundation for future initiatives where specialties converge for the betterment of the community. With these words, I warmly welcome all of you to this academic journey. Let us learn, share, and grow together as we work towards making eye allergy care more effective and patient-centered. Thank you, and I officially declare this webinar series of eye allergy is open.
Thank you, sir, for your wise words. We are truly honored to have with us Dr. Namrata Sharma, esteemed chairperson of the Scientific Committee of the All India Ophthalmological Society, a world-renowned clinician, researcher, and academic leader. Her visionary leadership and approachable nature have made it possible for the AIOS to partner with the IAP Allergy chapter in co-hosting this landmark series, underscoring the importance of interdisciplinary partnership for patient care. I request Dr. Namrata Sharma for her welcome address.
Thank you, Prabhat. I think it is a pleasure to have this webinar, which, like, has already been emphasized, where specialities are converging. We try to do subspecialties of ophthalmology, try to converge them, but I think for the first time, we are having a systemic discipline of medicine, that is pediatrics, and especially the IAP allergy chapter, collaborate with the All India Ophthalmological Society for a very important topic, and for a topic which is not understood well when you actually look at it in isolation, especially the pediatric eye allergies. And it is good to note that there'll be an allergy flyer also, which will be floated, which will be released today in Hindi and English both. I would like to thank Dr. Shweta Agarwal, who's been the person behind this series of webinar, and it is going to be 3-day series, who's helped to coordinate this from the All India Ophthalmological Society and got both the systemic disciplines together. There are so many things in pediatric allergies which we don't understand, which are actually linked systemically. But our vision, or you can say it is such a tunnel vision that we treat only the eye and never look at the patient holistically. And I'm sure there will be great insights also for the pediatricians from the ophthalmology point of view, because they also must be having ocular allergy as a part of the systemic allergy in children. So thank you so much, and I'm sure it will be a great learning and educational as well as benefit for both the ophthalmologists and the pediatricians.
Thank you, Namrata ma'am. Thank you so much. So now I would like to invite our first speaker, Dr. Shweta Agrawal. She is an internationally renowned ophthalmologist with her pioneer work on cornea and ocular surface disorders, and currently working as a senior consultant at Sankar Netralaya, Chennai. Passionate about education, she co-founded the Ocular Surface Gurukul YouTube channel aimed at elucidating ocular surface disorder and surgical techniques. She will be opening the session with classification and clinical presentation of eye allergies. I request Dr. Shweta ma'am to start the session. We will be having 1 or 2 questions after each talk. Dr. Shweta, please.
Thank you. I guess you would like to introduce the panelists before I start. So by the time I share my screen, would you like to introduce the panelists? We have esteemed guests as panelists here. Prabhat, would you like to take that?
After talk, we can, madam, before panel discussion, we can introduce.
Sure.
Okay, so we can start first session.
So my slides are visible?
Yes.
Yeah, okay, cool. So thank you so much again. And I'm very honored to be the opening batsman for this webinar. So today I'll take you through the classification and clinical presentation of ocular allergy. I'm Shweta, a senior consultant at Sankar Netralaya, Chennai. And what is ocular allergy is basically an inflammation of the conjunctiva due to the allergic or hypersensitivity reactions, which may be immediate or delayed to specific antigens. It is either an IgE or a non-IgE mediated reaction. Now, when we talk about classification, it is a clinical or a pathophysiological classification. Clinical is basically based on how the patients present clinically, so their signs, symptoms, the frequency, and the severity. So it is seasonal, perennial allergic conjunctivitis, vernal, atopic keratoconjunctivitis, or the giant papillary conjunctivitis. Based upon whether it is IgE or non-IgE mediated, both you have VKC, AKC, and the contact dermatoconjunctivitis, which is both IgE and non-IgE component, and the seasonal and the perennial are primarily IgE mediated. Now, when we talk about seasonal and perennial, most of them usually have a systemic component of allergy like rhinitis, and they present with a ocular rhinoconjunctivitis. They might be sensitized to allergens like dust mite or animal dander. The symptoms are seasonal in the seasonal variant and perennial in the perennial variant. They usually have a mast cell degranulation and histamine release, following which the patients present to us with irritation and itching. And the late phase eosinophil activation and neutrophil infiltration are usually not seen in this variety. The patients often present with itching and redness of the eyes. There is no corneal involvement, and usually, which is why they don't have any visual complaints. Now, these patients are often already under the care of allergists as they have a systemic component of allergy. And the topical therapy would be mostly mast cell stabilizers like sodium chromoglycate, which you would prefer to start at least a month before the symptoms start in the seasonal variety. Or it could be the dual acting like olopatadine or L-captidine or any antihistaminics. Moving on to vernal keratoconjunctivitis, which is a bilateral recurrent ocular form of allergy. A male predominance is often noted, mostly with a childhood onset, seasonal in most cases, but in tropical countries like ours, we often see the perennial variant. Diagnosis is primarily clinical, and types, it is basically of 3 types. When the limbus is involved, it is the limbal variant. When you have the tarsal conjunctiva primarily involved showing the papillary reaction, it is tarsal. And when you have components both, then it is mixed. Now, in the active stage of the disease, patient often presents with itching, watering, redness, blurred vision. The patients will have conjunctival hyperemia, a papillary reaction which could be limbal or tarsal, ropey discharge, Horner Trantas dots are often seen. Sometimes, because of the tarsal papillae causing a mechanical rubbing or the eosinophilic toxic materials released from the Horner Trantas dots, these patients present with a shield ulcer, which is an oval ulcer in the superior part of the cornea with fibrin plaque over its base. In the quiet stage of the disease also, patients often give you symptoms of itching on and off. In our part or the Asian population, we will often see patients with a brownish discoloration of the eye and diminution of vision if they are the severe ones. Signs clinically, you will see a conjunctival pigmentation and pseudogerontoxon, which is just a whitish ring in the perilimbal area on the cornea. Now, often these patients have associated atopic dermatitis, either on their legs or in the arms, or often even just on the eyelids. Now, this can be labeled either as atopic keratoconjunctivitis, or you can call it a vernal keratoconjunctivitis with atopic dermatitis. The severe version of the atopic keratoconjunctivitis often has conjunctival scarring or tarsal scarring, or can also have cataract, two features which we often don't see in patients with VKC. Otherwise, the clinical presentation is very similar to how patients with vernal present. Now, in severe cases, when we see patients often in the late stages of the disease, patients can present with a corneal scar, which often indicates a old resolved shield ulcer. Complications like limbal stem cell deficiency, keratoconus, which is an ectatic cornea where the patient has diminished vision, and a steroid-induced glaucoma or cataract. Now, we define persistent symptoms as frequency more than 4 episodes per year, and chronic persistent symptoms are less than 1 month of symptom-free period. Now, there are multiple classifications which are available for VKC, like the Bonninese, Gokhle's, but all of these were based on the disease activity. So the patient had to present to us with an active disease, and based on these signs and symptoms, these classifications are based, and treatment according to the grading. However, what they lacked was, what do we do when the patient presents to us in the quiet stage of the disease, but still has on and off episodes of activity, or he presents to us with a corneal scar or a complication? How do we deal with those patients? So we came up with this universal grading for vernal keratoconjunctivitis, which also received the best paper at the European Allergy meeting held in 2024. Here we have graded the VKC based upon the signs and symptoms, whether the signs are present or not, irrespective of that. So if they are mild, the patient could present with mild seasonal symptoms with or without signs. Moderate, the symptoms become a little more persistent, but there is still no corneal involvement. In severe, the corneal starts getting involved. The symptoms are more chronic and persistent. Patients might have intermittent signs, or they could just be asymptomatic with corneal telltale signs like the scar that we just saw. Or the very severe versions, where they could be just asymptomatic with complications like LSED, keratoconus, or a persistent symptom with corneal involvement. Now, based on this grading, we have also advised or recommended a treatment protocol, which is, seasonal dual-acting agents. Seasonal use of dual-acting agents in the milder ones, where in the moderate ones, you need to add on low-dose topical steroids during the active stage of the disease, and ask the patients to continue with the dual-acting anti-allergics perennially. At this stage, we often advise or recommend that the patient is referred to an allergy specialist, because the minute the symptoms become persistent, there could be a possibility of a systemic involvement, which we are clinically missing. Once they become severe, you had all of the above, to which you can add topical immunomodulator like your cyclosporin or tacrolimus, and a surgical intervention wherever required for your GPC or the shield ulcer. In the very severe cases, again, all of these, along with to step up, reach the maximum concentration of topical immunomodulator available in your area, along with pulse dose of high potency topical steroids or short course of oral steroids. Again, referral to the allergy specialist is mandatory, because here you will get a different perspective, see if you're missing out anything on the systemic aspect, which will help control the ocular component as well. Now, so the universal grading system basically incorporates the telltale signs of previous corneal involvement. It includes complication in addition to the symptoms, and irrespective of the disease activity, the disease severity increases with presence of complications or corneal telltale signs. The treatment algorithm includes role of immunomodulators, which is important to avoid steroid-induced complications, and also referral to allergists, because we all know that rhinitis or subtle dermatitis may go unnoticed by us. Now, the treatment guidelines are basically explain the nature of the disease, avoid allergen if possible, cold compresses, and tear substitutes to flush off the allergen. Now, let's go through a few cases. The milder ones usually are mostly seasonal. And like we said, the dual acting medications do very well. In the moderate cases, the minute they become moderate to persistent symptoms, you might need the dual acting medications to continue, like your olopatadine or eltaptidine or bipotastine for a little longer time, along with on and off low dose steroid during periods of activity. And don't forget the allergy specialist here. So these are the different topical medications that are available. Often the vasoconstrictors and NSAIDs are not something that we often use. The dual acting agents and the soft steroids are your main group of drugs which come as your friends to manage these patients. Now, they are available in different concentrations from 0.1 to 0.7 with olopatadine and 1 to 1.5% with bipotastine, dosage varying from once a day to twice daily. Topical steroids are primarily indicated only when the disease is active and you have, thick mucus discharge, severe corneal involvement, basically when you're dealing with persistent severe symptoms. Prefer to use short duration of pulse therapy with softer steroids like loteprednolone or fluoromethanol, and avoid high-potency steroids as much as possible. In the severe cases, once the cornea starts getting involved, you will have to add the topical immunomodulators in addition to using on and off steroids during the periods of activity. The topical immunomodulators that we are talking about are primarily tacrolimus or the cyclosporine. Again, they are available in different concentrations. Tacrolimus is statistically known to have a little more better effect and an early response than cyclosporine, and is more tolerable also to the patients. However, with the aqueous variant and the nanoparticle versions of cyclosporine being available, the tolerance to the cyclosporine also has significantly become better. In the very severe cases where you have BKC with a limbal stem cell deficiency and there is no systemic ailment, just going back to the history and identifying the inciting or the triggering factor, which was the hot weather for this child, just shifting him to a hilly area and moving him to a boarding school there helped. And it's been more than 7 years that we've been able to maintain his visual axis is clear, his vision is maintained at 6/9 in both the eyes, and the limbal stem cell deficiency is status quo. So we just took care of the inciting factor and the eye is doing better. In addition to the childhood onset that we were talking about, we also see an adult onset variant of VKC-like disease, where the patient did not have anything before 16 to 17 years of age, and they started complaining of itching and redness like this patient, a 20-year-old male, since 1 year. He was on topical olopatadine and lubricants with which the episodes of activity were under control. On and off, he needed low-dose topical steroids. Serum IgE was raised, but otherwise he had no systemic ailments. The allergist did not ruled out any systemic component. Another patient who similarly a 22-year-old who had itching and redness since 2 years, but his IgE was normal. So you do have an adult onset VKC variant or VKC-like disease where you could have an IgE or a normal IgE levels also, like the patients or the children present with. We have reported a short series where we have compared the adults with children and found that clinically there is not much difference in the way they present, other than the complications being a little more in children, probably because of the longer duration of the disease. To summarize, patients with ocular allergy have variable presentation. We do have an adult onset VKC-like disease. The universal grading system which has been proposed bridges the concerns due to sign-symptom discord. It focuses on the telltale signs and complications to grade the disease severity, and disease and treatment-related complications can be sight-threatening, and therefore referral in moderate to severe cases to an allergist is often recommended. Thank you so much.
Thank you, Sweta ma'am, for very lucid presentation. I want to ask one question. As a pediatric or as an allergist, what are the corneal signs we can see in patient? Because we are not accustomed to see, we can diagnose conjunctival redness, edema, but cornea, we are, we can, what are the common corneal signs we can see as a
The
allergist?
So the first thing would be the presentation. The child will come to you with severe watering and he will have photophobia. He won't be able to tolerate the light if the cornea gets involved. Second, they will tell you that there is a whitish opacity all around the limbus or around the cornea. So that is where, the limbus starts getting involved. So these two are very common presentations with which the patients present, other than, the itching or the redness or thick ropey discharge that we often see in these patients.
Okay, and second question is, at stage 1, why we cannot go for the allergy testing, as we can see almost 40 to 50% are associated with indoor or outdoor allergen. So if we diagnose at stage 1, you classify, refer allergist at step 2, 3, 4. So before going for the progression of disease, we can early diagnose our allergen and irritants. So that will be the useful thing. If you
Yeah, not
include.
a bad idea, Dr. Mitesh, but what I'm talking about is the step one is a seasonal, where it's only during seasons that they have. So usually the patients are not very keen to refer or meet a systemic or an allergist because they're like, ma'am, साल में 2 महीने होता है, उसके बाद we are okay. So we can definitely give an option to the patients. That is, it's not that it's a no. It can definitely be done. But a lot of times, a basic history at our level and seeing that there is only seasonal, 2 months, 3 months, they are fine. So we usually don't push them for.
Okay, so we can say that if patient is having stage 1 with comorbidities like allergic rhinitis, asthma, or atopic dermatitis, then we can go for the allergy testing, right? Thank you, ma'am. Thank you.
Thank you, ma'am. I would now like to take this opportunity to invite our esteemed panelists. We've already been introduced to Dr. Namrata Sharma, ma'am, and Dr. Neeraj Gupta, sir. I'd like to invite Dr. Ritu Arora, ma'am. She's a distinguished senior consultant, cornea and refractive surgery at Shroff Eye Center, Delhi, and she's former dean of Maulana Azad Medical College, New Delhi. Dr. Rohit Shetty, sir, we welcome you, sir. He's chairman, Narayan Netralaya, Bangalore, clinical and translational scientist, Grow Laboratories, and a leading cornea and refractive surgeon scientist with over 20 years of experience with a special focus on keratoconus and ectatic disorders. And he's credited with the development of the now almost iconic Pathfinder diagnostic kit. And I'd also like to invite Dr. Krishna Mohan, sir, leading pediatric allergy specialist from Kozhikode. Dr. Krishna Mohan is the immediate past chairperson of the IAP allergy chapter. And, I wanted to ask you 10 years back or so that we were not at all, really focused on the systemic aspect of the allergy as ophthalmologists. And now the more we ask, the more we dig into the history, we find that a lot of them have, in particular, allergic rhinitis. A few of them do have the history of allergic dermatitis as well. So in my practice currently, I'm referring, all patients. Sometimes we're not able to elicit the history, but they go to the allergist and they're able to elicit the history, or they do the pulmonary function test or the skin prick test. So I wanted to ask the panelists what has been their experience regarding the associated allergic comorbidities. Ritu ma'am, if you could.
Yeah, definitely. First, I just wanted to answer the question which Dr. Shweta was asked regarding the children with corneal involvement. I also wanted to add that number of these children also have dry eye. They may present with dry eye, they may just present with pricking sensation, additional to whatever Dr. Shweta has already talked about. And another thing is that because sometimes these 8 and 10-year-old children also have keratoconus because they rub their eyes so much and it invariably gets missed, and they may just have decreased vision and which may just go unnoticed. So definitely, if the child comes to an allergist, ophthalmic checkup is like both ways it runs. If it comes to us, it has to go to allergy specialist, and to allergist, it has to come to ophthalmologist. Now, coming to your point of systemic comorbidities, I do see number of them have dermatitis and in addition asthma. a lot of these children, if you just ask them the history of V's, is pretty common, and they always invariably give a history that they off and on have to use nebulizer, and that also with steroids, nothing short of steroids, which relieves them. And I find it somehow more often in patients other than VKC. In VKC children, I find less of systemic comorbidities, but in other allergic conjunctivitis or maybe AKC, I find these systemic comorbidities more often. And dermatitis is there, but I have seen atopic dermatitis not in younger children, but usually when they are in their teens, usually after the age of 14 or 15, or even if when they become adults, they come with dermatitis, which may be missed. And the dermatitis may be just in the form of lesions around the lids, which they may present with comorbidities. Rather, I just wanted to share one case which we are dealing right now. Very unusual, though we are talking about pediatric allergy, but this is a 23-year-old child. He had undergone PRK. So I rather wanted to take the help of the panel also to tell me. I'd undergone PRK, and 1.5 years down the line, the person comes with recurrent epithelial defects, recurrent epithelial breakdowns. And it's only when we everted the lid, we found very severe allergic symptoms on the lids. So, though in children this kind of thing may not come up, but once it is missed and they become adults, and it may not be a full-blown atopy, but if suppose some procedure is done, they may come with repeated epithelial breakdowns and dry eye. So that's what I had to say.
Thank you.
Thank you. Thank you so much, ma'am. Moving on to the next talk, I'd like to invite our next speaker, Dr. Swaminathan Sethu. Dr. Swaminathan Sethu is a scientist immunology at Grow Research Lab, Narayan Netralaya Foundation, Bangalore. And I request him to speak on immunopathophysiology of the allergic eye.
Thank you. Thank you to the organizers, and good evening. And I hope I'm audible and my PPT is visible at full screen.
Yes, sir. Go ahead.
Thank you. Thanks again. And as per the organizer's advice and Dr. Shweta's guidance, we have put together a pathophysiological process in ocular allergy in a translation or a clinically relevant manner. So the important part of the ocular surface immune system, as we all know, it's part of the mucosal immunology or mucosa-associated lymphoid tissue. And now we have a large section from the lacrimal gland to the nasolacrimal duct, including the entire surface, and we call it the eye-associated lymphoid tissue, teeming with a lot of immune cells, different types of immune cells, and most important, some tissue-resident immune cells such as the mast cells, NK cells, as well as the innate lymphoid cells. So though they do form part of both the innate and the adaptive, but they also form part of the continuum, because these are the cells which are going to be active contributors in various ocular allergic situations. And just to summarize what's happening on the surface, because this may be of relevance to understand the pathophysiology, we call it the triad. The triad is going to be the tissue, that is the stromal or the structural cells, the epithelium, and they may be producing key factors that will be interacting with tissue-resident immune cells, such as macrophages, dendritic cells, gamma delta T cells, mast cells. I'm talking about in normal situations. So this left-hand side is going to be a very healthy interactions. And at the same time, we also invite, the ocular surface invites other immune cells for surveillance. And they also interact with the structural cells. And there's going to be an interaction between the invited immune cells, that is the trafficking cells, and the tissue-resident ones. So this continuous interaction is healthy and ongoing, but any disruption in the magnitude or persistent of one over the other leads to pathology. So I want to bring the whole thing in the example of with an accelerator and a brake system. So this is one of my favorite ways of doing it, because we often talk about the accelerators, that is the inflammatory cytokines and the histamines in the case of allergy, but we often talk less about the brakes, which is failed in the process. So I'm going to speak the pathophysiology in this context. And Dr. Shweta ma'am has beautifully explained the different types of ocular allergy, but I put together what are the various similarities and differences with reference to the underlying mechanisms. So it is a very busy table, but I wanted to say that most often the inflammatory cytokines are pretty common across the different types of the ocular allergic conditions, and sometimes they are IgE mediated, and sometimes they are mixed, and sometimes they are not. But eventually, it is the amplification, the inflammatory amplification, which is the key problem. So I wanted to divide the whole pathophysiology as three components: the cause of the effectors and amplifiers, and the affected. The affected is the tissue, and previous speaker, Dr. Shweta, showed that so beautifully. So I'm not going to talk about the affected at all, but rather about the cause, the effectors and amplifiers, and how the various treatment modalities are involved in this process. When I talk about the cause, I choose not to talk about the allergens, and I'm not even going to call them allergens, but I wanted to know what allows and converts a non-allergen to an allergen. That is, the cause I've divided into access, loss of tolerance, and lack of resolution as one of the premise which causes the ocular allergy at the onset. The access here, with reference to ocular allergy, I would call it a defective epithelial barrier. You would have a very intact epithelial barrier. That means you are not going to allow the pathogens, pollutants, or the so-called allergens from entering into the ocular tissues based on the defective epithelial barrier. That leads to the penetration and sensitization, and subsequently the immune process gets activated. So I find that is one of the most critical step in the process of ocular allergy. And let me have a laser pointer here. The next one I wanted to say is this defect in epithelial barrier integrity, which is a critical or the best component, could be because of a variety of situations. It could be a genetic, epigenetic, and tissue or environmental response, a systemic involvement, or a hormonal dysregulation, dysbiosis, ocular dysbiosis, or even gut dysbiosis, or inflammatory cytokines. A variety of one or two or three factors can lead to these defective epithelial barrier integrity, and that may be the essential component for the entry into the ocular tissue. So how can we manage that? I was just going through the ocular pharmacology and practice patterns from various clinicians, and I was thinking that the trehalose, based on publications from a variety of groups all over the world, has shown that it improves epithelial integrity, and not only that, it reduces the inflammatory factors as well. So this is something which we can bring into a mechanism-based advised practice system where we can have trehalose-containing eye drops. Whatever the management is ongoing, maybe a 3% trehalose can be an excipient in these drops. And also a back-free can be more better, so that we can regain the lost epithelial integrity if it has happened. The next one is loss of tolerance, and that is the most important part where conversion from a non-allergen to an allergen happens. Peripheral tolerance devised by the T regulatory cells are absolutely critical in maintaining acceptance of whatever we are coming exposed to, including our own proteins and tissue components, as well as whatever we are getting exposed to. But when the T regulatory cells, which are controlling the B cells, controlling the Th2 cytokines, including the mast cells, if they are going to be less or dysfunctional, that is going to lead to the conversion of a non-allergic pollutant or a component to an allergen. And this is what happens. The loss of peripheral tolerance due to overt inflammation, viral infection, can lead to allergen-specific T cells override and become unresponsive to regulatory suppression of the Tregs, or a T regulatory cell dysfunction could happen, and it is seen in allergic patients where there are a reduced number of T regulatory cells are there in these individuals, along with impaired function. Impaired function is assessed by IL-10 and TGF beta secretion, primarily IL-10. And allergic patients have also, genetic studies have shown that FOXP3, that is the molecular machinery which makes the Tregs function, is also defective. So one of the key things is loss of tolerance. And how is the cost being managed? All allergists are managing it so beautifully with allergen immunotherapy. And I think the most common ones is sublingual immunotherapy, which is being more effectively used. But there are other ones as subcutaneous, oral, intralymphatic, and epicutaneous, but sublingual, because of the ease of introducing this allergen and tolerance induction, it has been quite popular and effective. And the other aspect which also improves tolerance or T regulatory cell formation is specialized pro-resolution mediators, it is called SPMs in short. I'm going to talk about that in the next section, called the lack of resolution. So any insult which causes the issue is going to make the whole amplification cycle move on, but the body has its own mechanism to switch it back and resolve. When that does not happen, and it is going to lead to chronic inflammation. And anti-inflammatory is important to bring it down instantaneously, but in long term, we need the resolution environment in the tissue to be active. And the only way to do that is to bring about more specialized pro-resolution factors into the system. And they are lipoxins, resolvins, protectants, and medicines. And they are essentially coming from omega fatty acids. So if we can also supplement these patients suffering from allergic with omega fatty acids, boost their pro-resolution factors, you can improve their tolerance induction capacity, as well as the resolution of inflammation which has already begun. And on top of that, the resolvins can bring about, in addition to the reduction in the immune activation, it can reduce tissue changes in the form of fibrosis, and also put in a reparative immune cells in place. And the other endogenous resolution factor is vitamin D. We have seen an inverse correlation with IgE and vitamin D and clinical presentation. Here, NS stands for non-severe and S stands for severe. So boosting vitamin D is essential and also in the management. And that is at the cause of it. What happens at the effectors and the amplifiers? Everybody is familiar with this entire milieu of multiple cytokines, which are either IgE dependent or IgE independent. They are going to initiate a cascade of an inflammatory flooding in these tissue, causing the tissue damage. But how can we block that? We can block in many different ways. So we can have corticosteroids and antihistaminic at the beginning, or mast cell stabilizers, which can prevent the release. Calcineurin inhibitors, of course, in the form of cyclosporin and tacrolimus, and a whole bunch of intracellular signaling mediators, both at the tissue level, at the immune cell level, can be switched off in reducing the amplification process. So these are mechanism-based tuning down of the inflammatory cycle. Sorry. And there are lots of biologics which has come into play, and this is biologics in the sense most of them are monoclonal antibodies. Their targets are dominantly IL-5, IL-13. Of course, omalizumab is targeting the IgE itself, but you do have IL-5 blockers, IL-33 blockers, TSLP blockers, and IL-9, IL-4, IL-31. So these are your new age monoclonal antibodies or biologics which has come into play for systemic therapy, but of course we can definitely borrow some of it for ocular allergy management as well. You can see how specifically each of these cytokines are blocked, so therefore it stops the amplification. The T cell to B cell activation to form more IgE will be blocked if you are blocking IL-4. If you block the IgE itself, you will stop the mast cells from degranulation. And similarly, IL-5 and IL-13 does the same amplification blockade. So with that, I want to introduce to another concept, because there are a lot of T cells involved, and especially T follicular cells are involved, which are important for class switching. So I wanted to introduce lymphocyte functional associated antigen 1, or LFA1. It's an integrin. We would all have studied in Robin's pathology about diabetes, where there is going to be engagement of immune cells to the endothelial cells, and integrins are involved, like cell adhesion molecules, ICAM. So LFA1 binds with ICAM and brings about the cellular movement, and also it facilitates the movement of T follicular cells within the germinal center, where they will meet the B cells to produce IgE. And if you can block this T cell activation, because lifitegrast is an LFA1 antagonist, which is effective in this T cell blockade, which is being used in dry eye, can also be explored in the process. And Dr. Neeraj sir was talking about the biomarker kit. And yes, we are using this biomarker kit to get the inflammatory load and manage these cases as well. And this has become a common practice, especially spearheaded by Dr. Rohit Shetty. And it measures 8 different factors. All of them are inflammatory amplification factors beyond the Th2 cytokines. And we have also done some ocular surface immune monitoring using ocular wash. And we have shown, particularly in keratoconus, a whole bunch of NK cells were extremely high on the surface. And we saw that it was amplifying the entire progression by interacting with, these are not allergic patients, but they do have the lot of IgE. And we realized that IgE can bind to the Fc epsilon receptors on the NK cells, and they can give out itch factors, causes eye rubbing. And then that is a keratoconus progression continuum. And knowing this, we will be able to better effectively manage even a non-allergic condition where, like, keratoconus is involved in the realm of how we manage allergy. And to summarize, it is, while we manage the immediate needs, it's important to find what are all the causal factors. One of the most important factor is dysbiosis, which is going to tilt this balance. The most critical one is loss of tolerance. And anything we can do to improve tolerance, that is Tregs, peripheral tolerance, from performing much better than its usual, you will be able to tilt the balance, and you can have a long-term resolution for our patients. And I take this opportunity to thank all our clinical colleagues who have been very helpful in me understanding ophthalmology and ocular allergy in this case, and BroLab members who have been very helpful in carrying out many of these immunological assays. Thank you very much.
Thank you, sir, for that wonderful presentation.
Thank you, sir. Thank you, sir.
You know, trying to bridge the gap between the treatment of the disease and the understanding of the pathophysiology. I'd like to request Dr. Rohit Shetty, sir, to please speak a little bit about the BioM Pathfinder and the clinical usage thereof, and how we may integrate that into a clinical practice on a fairly regular basis. Sir?
Sorry, I had to keep my camera off. I'm in my estate. It's not a good connection. Sorry for that. But like I said, Dr. Swami has demonstrated its role. And here we started with just 8 panels, of which a few of them have been linked to allergy processes. But the next version of it, we can look at just a simple allergy panels, where we look at some of the T-Rex related ones, or we can look at TH2 related markers, and this will help in a big way. The reason is there was one slide which Swami showed where there is a huge number of new biologics which are coming out. If you really look at those biologics, 99% of the next wave of biologics coming, even whether it's in ocular surface or in pediatric allergy, it's all going to be driven at modulating the immunology or targeting a specific immune responses. Now the question is, we have fantastic biologics, but the big challenge is that we don't have something to measure if it's going to treat or not. It's like having a fantastic insulin, but not knowing, if there's no knowledge of whether you are targeting high sugars or not, the whole biologics becomes shooting in the dark. So where I see the role of immunological pathfinder is combination or a synergy of targeted biologics and something which can look at what are we targeting. For example, if there's a high ICAM1, we know we have a drug called lifitegrast, which can be used right away. If you have a high IL-6 or IL-4 or one of those things what he showed, then we need to really look at which one will work well. So it is very important as we move on to bring this synergy. And that's where the biomarker pathfinder will bridge the synergy of immunology with targeted therapy. So this is what the bridge is going to be.
Excellent, sir.
Wonderful.
Excellent.
Wonderful.
So now I would like to invite Dr. Krishna Mohan, a leading pediatric allergy specialist from Kerala, is immediate past chairperson of IAP Allergy Chapter. He will be talking about history taking and systemic evaluation in patient with suspected eye allergy. So we all know that in allergy, history is very important. So Dr. Krishna Mohan, sir, please start.
Hi, good evening. My screen is visible?
Yes, sir.
Okay, so I will make it full screen.
Full screen.
Okay. Is it full screen now?
Yes, sir. You can
Okay.
start.
So at the outset, let me thank IOP Allergy and Immunology Chapter AAOS, and especially dear friend Dr. Veeras and Dr. Shweta Agarwal for giving this wonderful opportunity, and I congratulate them for bringing out this very useful initiative. So in the next 15 minutes, I will be talking on the history taking and systematic examination in a case of not only eye allergy and allergy as a whole. So I will be discussing these points, a general approach, and 3 points specific for allergy points, which is proper history taking salient features, and a few points regarding the head-to-foot examination. Before starting this, we should all remember allergy is not a local disease. It is a systemic immunologic dysfunction with local manifestations rather than a set of discrete autonomous symptoms. We all know the different manifestations of allergy, the allergy spectrum, starting from the skin, dermatitis, allergic rhinitis, asthma, and eye, everything. But when we want to analyze or interpret a case of allergic etiology, the most important part of that is history. So history is a very, very important bit. So the basic approach is almost similar to the standard medical history. You all will be very familiar with starting with presenting complaint, history of the presenting complaint, past history, the antenatal, natal. I think the ophthalmologist here may not be aware, but this is the usual pediatric history, dietary history, family history. Everything is similar, except this environmental history. It should be given more importance in the case of allergic disease because it has to be given a special place, and that has more time has to be allotted for environmental history. So the age of the patient, starting from the age of the patient, that itself is important in identification of the allergen, because we all know there are perennial allergens like the indoor allergens like house dust mite, or some seasonal allergens like the pollens. So we should know that sensitization to the seasonal allergens like pollens, it may take several years to develop, whereas in the perennial indoor allergens, that may be the first sensitization which will be seen in infants and small. So these small points are very, very important. Now coming to the presenting complaint, Shweta madam already talked about the presenting complaint in an eye allergy, but we should have a knowledge about the other allergic manifestations. First and foremost question to answer is it allergy? Because it is a very loosely used term by the public. For everything that they do not like, they will be using the term, I am allergic to that, I am allergic to that. So we should be very careful in stamping a patient as an allergy without doing a preliminary history or a investigation. So never assume that all patients coming to an allergy clinic are having some form of allergy. So allergy history, it involves determining the symptom complex and its relationship to the allergen exposure. So unlike the other systems like cardiology or GIT, the most important part of an allergy history taking is the close relation between the symptom and the trigger, that is the allergen exposure. So the onset of symptoms has to be asked, when did it start? What is the character of the symptom? How far it is lasting? How often it is presenting? Severity of symptoms? All these questions are very important. And another important point is we have to differentiate in allergy history is the symptom IgE mediated or non-IgE. I will be talking about the difference between IgE mediated and non-IgE mediated later in my presentation. So these are the hallmark symptoms of a IgE mediated allergy or a type 1 hypersensitivity. So it can present with itching, watering of eyes, sneezing, congestion, urticaria. So it can present in any part of the body, starting from the eyes and completely can involve skin or GIT, respiratory system, any organ it can involve. So we should answer this question. Is there a identifiable trigger? So the triggering factors in allergy, we have the allergens or the irritants. So the important question that we need to answer here, is there a temporal relation? Is there a temporal relation between these allergens or irritants and the symptoms? The second important point is there reproducible. One time when the patient took a food, he got a particular symptom. Again, when the same food is consumed, again when he is getting the symptom, that is what is called as reproducibility. You should also take the history of whether it is seasonal or perennial. That is, the symptoms are there all round the year or only there only during some specific seasons. So these are all very, very important points. This is another concept which is called as the cofactors. So cofactors are nothing but certain factors which per se won't produce an allergy, but if they are present, it can exacerbate or trigger the symptoms of allergy. For example, a patient who is on NSAIDs, in some patients of food exercise-induced anaphylaxis, exercise is a cofactor. In certain other patients, stress can act as a cofactor. So this may exacerbate or trigger the symptoms of allergy in its presence. So past medical history is extremely important in a case of allergy because I am introducing you to another concept of this atopic marks. So what is atopic mark? Atopic mark is nothing but the systematic way or a specific way in which the allergic diseases are manifesting, starting from atopic dermatitis. Usually it starts with atopic dermatitis and slowly it proceeds to the other systems like the skin, atopic dermatitis, food allergies, the upper respiratory system where it produces the allergic rhinitis, and when it goes down, it presents as asthma. So this peculiar way in which the allergic diseases are manifesting is called as this mask is called as the atopic mask. So that is very important when we take the past history. So if the patient is presenting with allergic rhinitis and allergic rhinoconjunctivitis, you need to ask whether there was a past history of atopic dermatitis, whether there was a history of food allergy. All these things are very closely related. So we should remember among the respiratory allergies, roughly around 80% of asthma patients are having allergic rhinitis, and around 40% of the allergic rhinitis patients are having asthma, and 75% of atopic dermatitis are having an associated rhinitis. So they are very closely related. They are together, and a specific past history is extremely important when we read these situations. So multiple allergic diseases can occur either concomitantly or sequentially. We should also take the past history of autoimmune diseases, thyroid disorders, past history of surgeries. Why? Because certain patients who may be presenting with latex allergy, they would have presented before with severe anaphylaxis when they had done a surgery previously. So these are all very important points. Past history of otitis media, sinusitis, anaphylaxis is very, very important that we have to as the patient's treatment. The personal and family history. It is usually we say that allergies run in families. So this is a very beautiful study which has pointed out the close relation between the genetics and allergic reaction. So this is a study based on asthma where they found that if there is one parent who is having an allergic, there is 25% recurrence risk in the child. And if there are two parents or both of them are having allergy, there is around 50% of risk of allergy. So this, so allergies and genetics, they are closely related. And that is also very important when we take a history. So this I already mentioned. Separately, when we consider the other systems of like the GI system and cardiovascular system, allergy it is specific in the environmental history is the most important. So we have to take a detailed environmental history. So we have to ask which type of house they are residing, or what about the roofing, the carpets, are they using heavy curtains, how they are cleaning the floor. All these things are very important. And are there any leaky walls? Are there any water damage? Because we know the allergens, especially the dust mites and mold, they are usually seen in places where there is high humidity. So they are very closely associated with the high humidity. So anything which is predisposing to this humidity, like leaky walls, any water damage, that we have to specifically add. What are the pets? Because especially pets like cats, they are highly prone to produce allergic manifestations. The occupational history is important. Another important thing is the tobacco exposure. That is an extremely important thing that we should remember. So tobacco smoke, we should remember in this one point which I usually tell my patient, whatever treatment you take, whatever test you are doing, until and unless you take care to avoid the environmental tobacco smoke or the tobacco exposure, your symptoms won't get controlled. So that is very, very important. We know there is something called as the first-hand smoking, second-hand smoking, and third-hand smoking. Everything is important. Third-hand smoking is nothing but the particles of tobacco which are getting attached to the parents or the relatives' clothes when they come close to the children. That itself is more than enough to produce the allergic symptoms. So that is third-hand smoke. So first-hand smoke, second-hand smoke, third-hand smoke, everything is important. And it's very important to remember if the mother who is pregnant smoking during the antenatal period, that itself can produce allergy in the upcoming kids, because there is some what is called as the epigenetics, which can change the whole system and make the patient allergic in the later life. So this is another paper which we have published in around 2018. This deals with the tobacco and side effects and adverse effects in children. So it is available for download in the Indian Journal of Pediatrics. So coming back to the environmental history, tobacco exposure is very important. Wood burning stove. So nowadays, majority of the houses may be using the gas stoves, but still, especially in the rural settings, there will be people who will be using the wood burning stove. So we should remember this old type of biomass fuels. They produce a lot of air pollution, especially the particulate matter, carbon monoxide, sulfur dioxide, nitrogen dioxide. So these can act both as allergens as well as irritants and can predispose to allergic rhinitis and exacerbate allergic rhinitis and asthma. So this is another interesting study which has proved that even a common incense stick which we use for our puja purposes, that itself contains a lot of toxic chemicals like carbon monoxide, carbon dioxide, nitrogen dioxide, everything which can predispose and which can exacerbate the symptoms. This is another interesting study which proved that the mosquito coils, especially these are used in the rural settings. One mosquito coil, when burned in a closed room, is equivalent to smoking 51 cigarettes. So it's a very interesting finding. It is almost equal to smoking the 50 cigarettes. And it will produce the same amount of particulate matter of around 75 to 130 cigarettes. So all these things are important when we take a history. We have to specifically ask them whether the child is exposed to any of these pollutants. Now coming to the treatment history. We have to ask whether the child is on any particular drugs like ACE inhibitors, NSAIDs, which can, both of them can exacerbate the allergy symptoms, beta blockers. Equally importantly, certain drugs like herbal medicines like Ayurveda medicine, homeo medicines. So people usually have a misconception that they are extremely safe. They don't cause symptoms, but they are also very, very important to be asked. History of treatment received and response to treatment, history of immunotherapy, all these things specifically are here. Now coming to a disease-focused history taking. So as you said, as Dr. Shwetanam already mentioned, we discussed about the history and everything in allergic conjunctivitis, but we should also remember the other systemic allergic diseases which can coexist. So we should have a basic knowledge about the cardinal symptoms and some must know differential diagnosis. So eye allergies, I'm not going to detail because madam already discussed the main symptoms are itching, redness, eye discharge, swelling, and the blurring of vision. Allergic rhinitis, there are primary symptoms as well as secondary symptoms. Primary symptoms include nasal congestion, pruritus, rhinorrhea, sneezing, postnasal drip. There are secondary symptoms which are often, we miss these secondary symptoms, but they are very, very important. It includes headache, fatigue, cognitive impairment, snoring, sleep disturbance, and mood disturbance. These are all things we have to take care because it is not only sleep when the child and the whole life the child will be affected when they are having severe, moderate to severe allergic. So another question that we need to add is whether it is symptoms are seasonal or perennial. We should also remember the DDs. It need not be allergy always. It can be infective. It can be a recurrent common cold. It can be any of the non-allergic rhinitis like vasomotor rhinitis, idiopathic rhinitis, drug-induced rhinitis, or gustatory rhinitis. So these things also we should remember. Now, another important allergic disease, this is often referred to as the gateway of allergy. The first manifestation of the atopic march is the atopic dermatitis. So we should remember what are the cardinal features. So the three cardinal features of atopic dermatitis includes itching, cirrhosis or dryness, and the typical skin lesions. Among these, itching is extremely important. So it is an itch that rashes. So without itch, we cannot diagnose atopic dermatitis. So that is the most important clinical feature. It is the cardinal symptoms. So atopic dermatitis has got three phases: an infantile phase which lasts from 0 to 2 years, and from 2 to 12 years it is a childhood phase, and about 12 years it is an adult phase. So each of these age-based phases, they are having a typical pattern and location, and they will be chronic and the symptoms will be lapsing. Asthma, I'm not going to the details. All of you know, when you suspect asthma, when you are getting a atopic person with a typical history, which is the symptoms are produced by triggers, presence of seasonal variations, typical exacerbations and remissions, the nocturnal symptoms, presence of a polyphonic wheeze, good response to bronchodilators and steroids. When you are getting these findings, then we have to suspect asthma. Food allergy, we know there are two types, IgE mediated and non-IgE mediated. The commonly referred to as food allergy is the IgE mediated one, which is immediate, which manifests usually very fast within around 1 or 2 hours, whereas the non-IgE mediated is delayed and it takes around more than 2 to 7 days for the manifestation. So the most important thing to differentiate is that an IgE-mediated food allergy needs a very small quantity of food that itself is enough for producing symptoms, whereas non-IgE-mediated needs a large quantity of. So I'm not going to the details of this thing. The diary, this is nothing but it's a properly taken history, which all food, in which all quantity the patient has taken or consumed within the last 24 hours and the last 1 week of the symptoms. And from that proper diary itself, we can find out which are the triggering foods. Now coming to another important point which we should not miss. So far we discussed about allergies, but we should always remember all the patients who are coming to us need not be allergies. We should always also remember there is some other important thing which is called as the primary immunodeficiency. Because sometimes these recurrent respiratory infections, which we misdiagnose as asthma, the recurrent skin manifestations, which we misdiagnose as atopic dermatitis, there may be a serious underlying problem like a primary immunodeficiency or a hyper IgE syndrome, which can present with the skin manifestation recurrent symptoms. So this is the Jeffrey Model Foundation, which is used to diagnose a PID. This is having 10 symptoms of clinical signs If 2 or more of these warning signs are present, we have to suspect a PID. Due to lack of time, I'm not going into the details, but this is another easy to remember acronym which will help you to suspect a primary immunodeficiency or SPUR. This is nothing but if any infection which is severe, persistent, unusual, recurrent, or recalcitrant, we have to have a doubt regarding a primary immunodeficiency. Now, coming to the second part of the presentation, examination. So what all things are important in the head to foot examination in the patient? So before that, in general examination, as usual, we have to take the height of the patient, weight of the patient. We have to record the vitals. Because what is the importance of height and weight? Because in conditions like severe asthma or severe difficult to treat asthma, there can be some growth suppression. So if there is a chronic chest infection like cystic fibrosis, there also the poor weight gain can be there. In food allergy, if the child is on severe restricted diet, there also the weight of the child may be very, very less. So coming to the head to foot examination, the moment the patient is coming to our OP, we have to start our inspection. We have to suspect, are there any allergic manifestations? Some children will be showing this peculiar facial grimace. It is nothing but the peculiar facial movements. This is a compensatory measure the patients develop in response to nasal fixing. They will be showing all sort of facial expressions. This is what is called as a facial grimacing. Coming to the eye, these are very important findings. One is the allergic shyness. Allergic shyness is nothing but the blackish discoloration around the eyes. And there is the second thing, which is called as the Denny-Morgan fold, is nothing but the extra infralabial fold. So we should also remember what is the basic pathophysiology of allergic shyness. It is due to venous congestion, which leads to lower eyelid edema and dark discoloration. The Denny-Morgan folds, it is also due to the congestion. It produces the spasm of the Muller's muscle. On the right, you can see another sign, which is the Haddock sign, is the decrease in lateral eyebrows due to chronic scratching, which is usually found in both atopic dermatitis as well as the allergic conjunctivitis. And we all know in allergic conjunctivitis, the involvement of eyes is typically bilateral, and the discharge also. Shweta ma'am already described in detail about the eye discharge and all. Sometimes we will get a stringy or a rocky type of discharge in the VKC. And these are some other findings. You can see on the right side, you can see the typical keratoconus. It is nothing but the protrusion of cornea. And rarely, as a complication, you can get the ulcer also, which is called as a shield ulcer. You have to examine the ears also. You have to use an otoscope. Ideally, you have to look for the otitis media with effusion, which is very commonly seen in allergic rhinitis also. So that you have to examine with an otoscope. You can see in the posterior part of the ear, sometimes you will get the eczematous changes in the posterior auricular area. So this is nothing but the otitis media with effusion, which is also called as the glue ear. It is due to the nasopharyngeal edema around the eustachian tube. This causes the eustachian tube dysfunction, which leads to accumulation of serous, non-infected fluid in the middle ear space. So looking at the nasal mucosa, you should remember the color of the nasal mucosa in allergic rhinitis is classically described as pale to purple, compared with a beefy-red mucosa of patients with non-allergy. If there's an infectious rhinitis, like a common cold, you will see a very red mucosa. But here, it is typically pale to purple. So these are some other findings you have to look for. On the left-hand side, you can see what is called the allergic salute. Allergic salute, just to free the nose of the congestion. They will do the peculiar action. And the second picture is the transverse crease. Third picture is a nasal polyp, which is oftenly found in cases of sometimes in allergic rhinitis. But if you're seeing a nasal polyp, you have to suspect some other serious diagnosis like the allergic fungal rhinosinusitis or a cystic fibrosis also. What is this? This is nothing but the adenoid facies. So adenoid facies is often seen in severe allergic rhinitis, which is often having associated adenoid hypertrophy. You can see the long narrowed face, narrow upturned nose, open mouth, exposed upper incisors, and recessed lower jaw. This is another finding which is found in the pharynx, which is called as a cobblestone pharynx. It is due to the hypertrophy of submucosal and pharyngeal lymphoid tissue. And coming to atopic dermatitis and contact dermatitis, this is another feature which is called as the lip leakage dermatitis, which is produced due to the constant and recurrent lip leaking of the using the tongue around the lips. You have to auscultate. You have to see, because majority of the patients will be having allergic rhinitis and associated asthma. So you have to look for whether there is any bronchi, crepitations, etc. And a chronic long-standing asthma, there may be some chest deformities also, that also you have to inspect. And you examine the abdomen for any hepatosplenomegaly. As I already mentioned, all cases of coming to you may not be allergy alone. It can be some other serious diagnosis like a primary immunodeficiency. So these are some other skin manifestations like urticaria you're seeing. These are different phases of atopic dermatitis. On left-hand side, you can see the infantile phase, and on the rightmost side, you can see what is called as the thickening of the skin, which is found usually in the adult phase of atopic dermatitis. So I'm not going into the details of this. These are some clinical characteristics of various primary immunodeficiency disorders. They may be presenting with some dysmorphic facies or some typical skin lesions or albinism and all. So you should have some basic idea so that you won't miss this. Finally, you should also look for other systemic signs like cyanosis, clubbing, presence of any murmurs, noisy breathing, etc. So to conclude, a good history and targeted clinical examination is a must, and the skin and other lab tests, the skin prick test and other lab tests, it will be discussed in the next session. So they are having only, they will give only supportive evidence to a clinical diagnosis. Clinical diagnosis is the most important, and clinicians should be aware of the wide range of TDs in allergology, and we have to always rule out mimics. So thank you so much for your patient listening. I know I had to rush very fast because this is a very big topic and it's so difficult to finish it in 15 minutes. Sorry if I have rushed very fast.
So thank you, Krishna Mohan sir. Excellent, sir. History taking an examination. You have covered everything. So in any case of allergy, we need to take history. Either it's allergic rhinitis, conjunctivitis, atopic dermatitis, asthma, or food allergy. So it's a overall allergic disease we are treating. So very good, excellent, sir, narration by you. Now, Dr. Prabhat.
I wanted to ask, sir, about the role of family history in these patients. So let us say that you have a child with allergy, and often you have a brother and a sister walk in, both of whom may have, allergic eye disease and or associated rhinitis. So what is the role, and or what is the, inheritance mode, or is there some sort of...
Yeah, that is what I have shown on slide, where how far the allergies run in families. So that is, if there is one parent who is having allergy, there is 25% risk. Both parents, there are 50% risk, and one sibling, it is also 25% risk. So it very closely runs in families, and if one sibling is affected, there is a high chance that the other sibling also will get. And not only family history, the both of them are exposed to the same environmental conditions. So that is another thing. So family history is very, very important.
Okay, sir. Thank you.
Thank you.
So, after doing a good clinical evaluation, we need to investigate these patients. So let me invite Dr. Neeraj Gupta, sir, to enlighten us about the role of allergy testing in ocular allergy.
Thank you, Dr. Prabhat. And I must say that Dr. Krishna Mohan and I think the previous speaker, Dr. Shweta and Dr. Setu, have made my job a little easier. So I will be speaking about role of testing in ocular allergy. First of all, I would like to say that I do not have any conflict of interest because I am going to speak one or two laboratory names which are actually necessary to better understand the concept, but there is no conflict of interest. So I'll be a little bit once again going back to the ocular allergy spectrum and the topic which is common evidence, allergy test, which, when, how, and why, and then how one should approach in our clinics or in our outpatient department. And then I would like to summarize my talk. So this has been extensively discussed by Shweta and Dr. Setu, that clinical features of major ocular allergy syndromes, which are encompassing from the VKC to AKC, and then there is some blepharoconjunctivitis to giant papillary conjunctivitis, and then perennial and seasonal allergic conjunctivitis. But my area of interest here is that what is the allergic mechanism which is actually predominantly involved here. So what I want to say is that in allergic conjunctivitis, whether it is perennial or seasonal, it is predominantly or only mediated by IgE mediated pathway, which is a classical pathway of type 1 hypersensitivity. Whereas if we just see the other mechanisms, that could be the other phenotypes like VKC and AKC, these are having like a mixed type of immune mechanism, could be IgE mediated or non-IgE mediated. That means the tests which are destined toward IgE mediated detection or type 1 hypersensitivity, they might be useful here, might not be useful here. And then there are certain other you can say like manifestation of ocular allergy, like the blepharoconjunctivitis and giant papillary conjunctivitis, which are actually non-IgE mediated, and we might actually look for some other alternative immune mechanisms. So this has been beautifully explained previously about the launch of an allergic response. But what I want to say that everything which have been spoken previously by Dr. Rohit also and every other person, every other speaker, that the cornea or the eye is getting stimulated, or the dendritic cells are getting stimulated, and then whole the cascade is moving towards Th2 pathway and all the interleukins are released. My only question is that who is the culprit? The culprit is this allergen. So if this allergen is creating problem to a sensitive individual, to an atopic individual, then the things are starting. So what are these common allergens which are responsible? So this is one paper which is from 2013 about allergic conjunctivitis, the most common allergen in the northern Greece. And what they have found that apart from certain pollens which are regionally prevalent, dust mites are more there, and then pet denders which are important, that is the cat dender and the dog dender. And then there are certain fungal spores which have also been identified. What about India? To be very frank, there are no studies which I was able to get of, you can say, like allergen profile or sensitization profile in ocular allergies. But if we just see with other systemic manifestations, could be bronchial asthma and allergic rhinosinusitis, then at that particular time, there are so many papers. This is one paper from South India in which dust mite is once again the most common culprit. And then we also understand that insects, especially the cockroaches and then fungi and then pet dander. Among the pet, this study was actually in 2017, the dog is there. And then now the cats are also moving inside the house, and the cat dander is also coming an important problem, and then certain pollens. This is one study which we have conducted at our unit for past 5 years. The most common allergen sensitization in children who presented to us with respiratory allergies, that could be asthma symptoms or rhinitis or rhinoconjunctivitis, in which we have also identified dust mite and cockroach. These are the two most important sensitizing allergens or aeroallergens which are responsible. So if we want to, you can say like make a diagnostic pyramid, that how to diagnose. So the first and foremost thing is medical history, and thank you very much to Dr. Krishna Mohan, who have beautifully elaborated a lot about medical history. So medical history is the backbone. Medical history and physical examination, without which you cannot just write to the next step. It is the first step, there is no doubt about that. And after that, then we have to move towards some other test. But to try to understand these tests, let me revisit type 1 hypersensitivity. What is this type 1 hypersensitivity? If we just see carefully, whenever an allergen comes, here if you see in the picture, whenever an allergen comes in the contact with the, you can say like the TH-naive cell, and at that particular time, this TH-naive cell is converted towards Th2 pathway in an atopic individual. Now this Th2 pathway will actually stimulate the B cells to produce the plasma cells. And now these plasma cells produce the IgE antibodies. Now these IgE antibodies are the free IgE antibodies which are circulating into the circulation in the bloodstream, and this IgE antibody is having a very high avidity to mast cells and basophils. And ultimately this IgE antibody will get attached to the mast cell and the basophil and remain in the circulation in the bound form, which is bound to the mast cell and the basophil. Now, this waits for the re-exposure to happen. Like for an example, as Dr. Krishna Mohan mentioned about the seasonal allergen. So in the case of seasonal allergen, the sensitization is considered to happen in the first season and the re-exposure happen in the second season. That is why usually the seasonal allergies, whether it is, you can say like allergic rhinitis or some other manifestations, the seasonal allergies usually present after first year of life. They are seldom seen within first 1 year of life. Whereas the perennial allergen, even they can manifest even in infancy also, because the sensitization as well as the re-exposure can happen in the same year. Whereas in the seasonal allergen, it is the next year, the next season when it comes, then the allergen exposure or re-exposure will happen. Whenever the allergen will come again, then at that time it now get attached to the bound IgE, and thereafter this, you can say, like stimulate this histamine release or busting of the mast cell and the secretory granules, and ultimately all the manifestations happen. Now, if we just see very carefully here, there are two types of IgE molecule. One IgE molecule which is a free IgE molecule which is there roaming around into the circulation, another IgE molecule which is there bound on the mast cell. And the IgE molecule which is there bound to the mast cell, that is not even single, that is bound in the pair. If you just see here 1 and 2, so these two IgE molecules, they are sitting side by side together waiting for the allergen to come. And now this allergen come, and then it get attached to the couple IgE molecule or bound IgE, which is called as a coupling reaction. So what I want to say, whenever we are doing any sort of blood test for allergy testing, that is in vitro testing, it is actually detecting the free IgE, which is more sensitive test. And whereas if we are doing any sort of in vivo test, that in vivo test could be the skin prick test, it could be the challenge test. So any sort of in vivo testing, that means we are re-challenging the patient with the same allergen, and at that particular time we are actually testing the bound allergens or the bound IgE. So this in vivo testing or the skin test or the challenge test, they are more specific, they are much more near the clinical picture, whereas the in vitro testing are more sensitive. And the things which are more sensitive, they are having more negative predictive value. So the false positivity is higher and negative predictive value is much higher with the blood testing as compared to the skin testing. What is skin test? So if you just want to elaborate about the skin prick test basic, so this epidermis is the top layer, and then followed by rest of the other layers of the skin. And this epidermis is considered to be the bloodless and the painless layer. That means there are no blood vessels, there are no pain fibers which are there. And at that time, we are just putting an allergen drop over the skin, and then we are piercing it through the lancet. The lancet is removed. So basically, we are delivering the allergen only in the epidermis. An ideal allergen dose is 0.3 microliter, which is delivered at a depth of 1 millimeter. And thereafter, as per the concentration gradient, this goes down and ultimately it gets attached to the bound IgE on the mast cell, and then thereafter the mast cell will, you can say, like release the histamine, and the wheel and flare reaction will happen within 15 minutes. It is very simple, which can be done in the outpatient department, but you definitely require some practice. And I told you that it is actually considered to be near the truth. That means it is having good sensitivity, specificity, positive and negative predictive value up till the tune of 90 to 95%, especially in case of arrow allergens. So skin test is reliable, it is economical, easy to perform, results are available within 15 minutes. And the benefit is that it is actually detecting the bound IgE. That means it increases the specificity of the allergen. Whereas there are certain problems, because there are sometimes we do not have, you can say, like standardized allergen solutions for everything, which can cause problems. The test technique is also important. The person who is doing it as a new person, what is the person who has done for 10 years together. So definitely the test technique will depend upon the experience. Individual interpretation, that is also an important thing, and which can sometimes becomes, you can say, like borderline positive and borderline negative cases. It makes a difference. Sometimes unhealthy skin, as was mentioned, like atopic dermatitis, severe eczema, you cannot do it. If somebody who has already undergone some anaphylaxis, so all the histamine stores have been bursted, so you need to really wait for at least 4 weeks after anaphylaxis, then only you can probably do skin prick test. So I've already mentioned you, and then thereafter, if the patient is on antihistamine, because it is based upon a histamine test. So if the patient is on antihistamine, you need to stop the antihistamine depending upon the half-life of the antihistamine used. Usually 5 to 7 days is a reasonably safe time. If a patient is on oral steroid because of some reason, at least for 10 days or more, then you need to stop. If the patient is on anti-IgE therapy like omalizumab, you need to stop that for at least 6 months, and then only you can perform skin prick. Or sometimes if the patient, especially the children, they are anxious, parents are anxious, you cannot really do it. So then at that time, we need to go towards in vitro testing. Among the in vitro tests, we consider till now the total IgE, but total IgE is totally non-specific. It can be raised in so many conditions, could be infection, atopy, immunodeficiencies, and many other different conditions. In India, it could be parasites, even to the viral, to the post-viral conditions. So any of these conditions, even the pollutants, so all these can cause actual high total IgE. So this is considered to be non-reliable at all. It is not recommended routinely in allergy practice. It is neither sensitive nor specific for either making a diagnosis or ruling out allergy. So may be needed when anti-IgE therapy is indicated, because the dose of the anti-IgE molecule, that is omalizumab, is actually based upon this formula, and you need to really calculate, and this formula actually incorporates total IgE value, and that is why you need to do it sometimes, but otherwise routinely it is not required. So coming back now to the specific IgE, if we are not interested in the total IgE, and as I mentioned earlier, that dust mite could be there, pet denders could be there, pollens could be there, or cockroaches could be there, can we measure specific IgE to them? So the answer is yes. And the gold standard technique, which is considered to be called as FIA, which is fluorescent enzyme immunoassay, it is highly sensitive and specific, in which what is happening, that the allergen is already there in the bound form on a cellulose sponge, and on the top of that, the serum of the patient is passed. If the relevant antibodies are there, they will get attached to the allergen, and then an anti-IgE antibody, as you can see in the figure 2, an anti-IgE antibody will get attached to the bound IgE, which is actually attached to the fluorescent chemical. And with the intensity of this fluorescence, you can actually come to know that what is the concentration. So immunocap is basically the same, which is FIA, but it is a branded name, the proprietary name, which has been taken care by Thermo Fisher. So Thermo Fisher Scientific product for allergy testing, in vitro allergy testing, which is immunocap, is considered to be gold standard in vitro testing for allergy testing. But if somebody asks that what is the gold standard for allergy test, that is skin prick. If you cannot do skin prick, then at that particular time, immunocap comes to the rescue. And it is a standardized value which gives you the quantitative value. That means if you are doing the test now and the value is coming somewhere like 25, you have taken some action, probably some allergen avoidance or immunotherapy or something else, and later on in follow-up, the value comes out to be 2, then definitely the allergenicity potential has reduced from 25 to 2. It is having a quantitative value. But in the market, there are other tests which are available. These are like multiplex tests, and these are, say, like more economical, more cheaper tests. But the problem is that they are not quantitative, they are semi-quantitative. Here, you can say that something which is classified in the classes like class positive, class 2 positive, class 3 positive, or the grades, but it is not having an exact quantity, so these cannot be used in the follow-up of the patient. So the blood test of the serum specific IgE, they are convenient for the patient. There is no risk for severe reactions during the time of testing, no requirement of any stopping of any antihistaminic or any steroid or anything. Objectivity is there. You can get some numbers, and patient can also fiddle around with those numbers, roam around with these numbers. Any skin condition you can do, but they are costly. Blood sample is required. It usually takes 24 to 48 hours turnaround time, and they only detect free IgE. That means they are more sensitive. That means there are more chances of false positivity, especially if you are having, you can say, like high total IgE. And then suppose if we are not sure that what to test for, then at that time there are certain groups which have been created by these pharmaceutical companies, which is called as Fadiatope, which is once again based upon the immunocap. So that means if you're not very much sure that whether this particular person is following IgE mediated pathway or not following IgE mediated pathway, then at that time you can just perform a screening test, which is called as the Fadiatope child or infant. What's this Fadiatope adult? For a child less than 5 year or more than 5 year old, respectively. In less than 5 year, as Dr. Krishnan mentioned, that it could be some aeroallergen, that could be dermatophagoids, that means dust mite, some pet denders, certain pollens, and certain food items. Whereas in a bigger child, more than 5 year old or adolescent or adult, it is predominantly aeroallergen. That means 2 species of dust mite are covered, some pet animals or pet denders are covered, and then some pollens are covered. But here also in Fadiatope, cockroach is not covered, which is an important allergen, especially for this part of the world. So it is considered that the specificity and the negative predictive value of this Fadiatope screening is really 90% or so, which is good. This slide I was mentioning that suppose if the total IgE value of some child is very high, that could be probably 2,000, 3,000, 5,000, then at that particular time, the individual specific allergen values, these are not that much relevant. They can sometimes come false positive, which is important. So if I want to compare the two tests, one versus second, then the skin prick test actually wins the race, because it's the time to result are within 15 minutes. Patient satisfaction is much more there because you are doing some testing and within 15 minutes a wheal and flare reaction is happening. So patient can easily understand, okay, the doctor has applied a little amount of allergen and now the reaction is happening. So just assume that so much allergen which he is getting, you can say, like exposed to in the environment for years together, how much it must have caused inflammation. Clinically more relevant. Cost is also, it is more economical. And in case of high total IgE, skin prick is not affected because it is actually testing the bound IgE. It is not testing the free IgE. Then there are certain advanced techniques. I'm not going in detail, but these are called as like molecular diagnostics or component testing. So which is usually used in polysensitization cases. Sometimes you can say like many test positive, and you are not sure that what test is truly positive and what test is cross-reacting. Then at that time, you can take the help of cross-reactive component result diagnosis, in which what I want to say, the different allergen sources can share certain components, and these components individually can be tested by molecular testing or component result diagnostic. And this seems to be the potential futuristic tool, and there is limited literature available, at least for the ocular allergy. It has been predominantly used for certain other conditions like food allergies and others, but not for allergic conjunctivitis so much. Then there is another condition which is called as local allergic conjunctivitis, in which the allergic inflammation is mainly localized to the eye only. And whenever you are doing a systemic testing, that could be the skin prick or that could be the specific IG, the test might come negative. So you have to directly apply allergen there, which is the local allergic conjunctivitis. And at that particular time, you can either detect the specific IG local in the tear film of the patient to that particular allergen, or you can probably do the conjunctival provocation test. So this conjunctival allergen provocation test, in which you have to instill, you can say like the gradually increasing concentration of that particular allergen, and then you have to really see about the symptom score, and you have to see the reactivity score and redness score, and then you deduce that, okay, probably it seems to be the local allergic conjunctivitis. Then the another armamentarium is patch test. Patch test, sometimes you're using some antimicrobial or some antibiotic eye drops, or some probably ointment like neomycin ointment or several others. Then at that particular time, the patient is reacting to that. But this is not type 1 hypersensitivity. This is usually type 4 hypersensitivity, which is usually contact, because of contact. And if you want to really test that, then you have to do patch testing. So these are the different type of, you can say like chemicals which have been done, which have been used in the literature for ocular allergies for patch testing. So in the patch testing, you have to just use certain well-defined wells which are there, and you have to apply it on the patient back. And then after, let's say 48 hours or after 96 hours, and then after 7 days, you have to read the readings, and then you can get the reactions from negative to 3+ testing. So this is one position paper which was published recently in 2017 by Dr. Leonardi and Serge Doyen about the diagnostic tools in ocular allergy. And the recommendations are, if the skin prick test of the specific IG levels and allergen exposure history are in concordance, then it seems to be that this allergen is the causative cause for seasonal or the perennial allergic conjunctivitis. About the allergen provocation test or conjunctival provocation test and component result diagnostic, that should be considered in polysensitized patients. This provocation test is recommended when there is a suspicion of localized ocular allergy, and patch tests are required, especially in cases of blepharoconjunctivitis, because they are sometimes considered to be because of type 4 hypersensitivity. And in VKC and AKC, because I told you earlier that it is a mixed pathology, could be IG and non-IG. So sometimes you can get, you can say like the official trigger, but sometimes you will not get the recommended trigger. So last 2 or 3 slides. When an ophthalmologist should refer to an allergist, patients suffering from recurrent or persistent episodes of conjunctivitis with itchy eyes, and the allergy testing has not been done, or what exactly is happening. Patients suffering from conjunctivitis, and there is a strong family history, as Dr. mentioned, or personal history of allergy. Patients suffering from recurrent eyelid edema, patients suffering from eyelid eczema or dermatitis, and when allergy refer to an ophthalmologist, if a patient suffering from acute red eye or ocular pain or photophobia, patient with blurred vision, reduction in visual acuity, patient with lid or lid margin hyperemia, patient with diagnosis of OCG but negative skin prick or specific IG, then at that particular time there is a possibility of localized ocular allergy, and we might need our ophthalmologist colleague for conjunctival provocation test. Patient with suspected or diagnosed ocular allergy but poor response to treatment and persistent or recurrent need of steroids, or patient diagnosed with AKC or VKC. So to summarize, what test? It all depends upon history and geography. Wherever you are living, you are sitting in Chennai or probably Kerala or Bangalore, and at that time, your pollens, your environment will be different as compared to Delhi, Haryana, or UP. And then skin prick test versus specific IG, you can actually choose patient to patient. And then when it should be done in the recurrent or persistent symptoms, or if it is actually affecting the quality of life of the person, which is persistent or moderate to severe intensity. And why? Because you can actually execute the allergen avoidance and provide immunotherapy. So this algorithm, which was published in the same paper, the position paper which I just mentioned you, so the algorithm for diagnosis of ocular allergy, these are the typical signs and symptoms suggestive of ocular allergy, already mentioned, not going in detail. And if these are the symptoms which are there, like unilateral disease, foreign body sensation, ocular pain, purulent discharge, the elderly onset, then it is not likely or less likely because of the allergic manifestation. Then at that particular time, you have to think about differentials, which are already discussed and they are mentioned here. But suppose if the signs and symptoms are typical of ocular allergy, then at that particular time, you have to move towards the testing. The testing could be type 1 hypersensitivity or type 4, depending upon the presentation. And in the type 1 or type 4, the skin prick or the specific IG and the patch testing. And if they are coming negative, once again, you have to rule out differentials. But if they are coming positive, then at that time, you have to define that whether it is type 1, then seasonal or perennial allergic conjunctivitis, or probably a mixed type of a problem, or CPC if it is patch test positive. Whereas you're still uncertain, then at that time, secondary diagnostic tool that could be allergen provocation test or TRIG or eosinophils in the tears and scrapes and tear biomarkers, they all might be required. And if they are positive, once again, they are defining the specific ocular hypersensitivity disease. So with this, I would like to close my session here, and I would like to take the opportunity to release this flyer which we have created for eye allergy awareness. This is for the community, and we are going to release it today in the collaboration in presence of Eye Society, National Eye Society. So this is eye allergy awareness for the community, in which we have given certain points that what are the common symptoms, what are the common triggers, how you can really prevent the flare-ups, and what are the treatment options which are available, and a very special line which has been written that always take medications as per the advice of your eye or the allergy specialist doctor. Eye allergies are common but manageable. With prevention, proper care, and medical guidance, you can keep your eyes healthy and comfortable. Thank you very much for the opportunity. Thank you.
Thank you, sir. Sir, you have made very clearly that when ophthalmologist needs allergist and when allergist will refer to the ophthalmologist, right? Sir, I have one question. In VKC, we know that it's a sight-threatening emergency, right? So if family history is positive and no, we are not able to conclude that this allergen is likely to be the temporal relation with this allergy, conjunctivitis. So whether you will advocate SPT or not, no other personal history of allergy, no allergic rhinitis, asthma, or atopic dermatitis. So either we go.
If there is no suggestive history, then probably, as I mentioned you, that VKC and AKC, they have both the pathways, IG and non-IG. So IG pathway, once again, if there is a strong history which you are getting, then you need to do the testing. But if there is no strong history, then at that time, it might be following a non-IG mediated pathway, and probably the testing might not be helpful. But family history, majority of the time you will get, but it is not 100%. You will get always the family history. So sometimes you have to really see that, okay, this particular patient with this particular season or this particular type of environment exposure coming up again and again with the recurrent symptoms, then at that particular time, it is possible that still a component of IgE might be there. So even if we are unable to find out the complete cause, but if we are able to get at least one part of that and we are able to rectify one part, we can at least improve the quality of life.
Thank you, sir.
I had a question for Namrata Sharma, ma'am. You know, most of us are working in separate hospitals, and the pediatrician is in separate hospital. But at AIMS, you're all in the same hospital. So, what are the protocol that the ophthalmologists are following when referring to the allergists at AIMS Delhi, ma'am? Which are the patients that you refer, and what are the tests that they prefer to do in the allergy department?
If she's there, because I think she also had some connectivity issues.
All right, all right. So
Is
then I'd like to invite, Dr.
You can,
Shweta
is Dr.
Agarwal.
Is Dr. Ritu there or Dr. Rohit? You can.
Yeah,
Yeah,
Ritu
I'm
ma'am is
there.
there, ma'am.
Yeah, I'm there. Yeah. So, I usually, because I'm not really aware of many pediatric allergists in Delhi, but now after the webinar, I'm my wiser. But I generally refer the cases to a pediatrician to sort out the problem. And I have the IgE levels done, but sometimes, as they very clearly explained, sometimes they're high and sometimes they don't come they are very much within the normal range.
Okay. Thank you, ma'am.
Thank you, ma'am.
So,
Can we go for the panel discussion now?
we'll have the cases first, I think. I'd like to request Dr. Shweta Agarwal, ma'am, to start the first case. That is Dr. Sumina's case. Dr. Sumina Chatterjee is trained in cornea and refractive surgery at Shankar Netralaya, Chennai, and currently working as consultant cornea and ocular surface at Netralayam Super Speciality Eye Care and Sunayan Advanced Eye Institute, Kolkata.
The voice is not audible. Dr. Shweta, you need to share the voice from the device. Dr. Shweta, you need to go to the audio. Dr. Shweta, you need to go to audio and then there is an arrow upstairs. Then you need to click that and then audio settings will come.
Okay, 1 second.
In the audio settings, then you need to change it.
Stop sharing. Yeah, I'm doing built-ins microphone, right?
Yes.
Yeah. Sorry.
Bihar, who presented
okay
with
now?
this markedly
Yes, it's perfect.
opacity in cornea in the right eye. The main finding that directed us to the most probable etiology was the presence of pseudogerontoxin in both the eyes. This pseudogerontoxin is found in vernal keratoconjunctivitis, and on further inquiry, the parents did inform us about the intense itching and constant eye rubbing habit of the kid. But the parents were unaware that the child had only hand movement vision in the right eye and counting finger 2 feet vision in the left eye. This is usually a self-limiting condition. This is known as acute eye drops, which occurs in keratoconus. That is a result of constant eye rubbing in a case of vernal keratoconjunctivitis. We planned for pneumodesmatopexy in this kid as the age is amblyogenic, and as we were waiting for getting the general anesthesia fitness for the child, we prescribed topical steroid for this condition. But within 4 days of starting the topical steroid, the child presented with this ominous-looking pseudomonas corneal ulcer, which luckily started scarring within 1 month of starting hourly ceftazidime. After 6 months, we did optical penetrating keratoplasty for the right eye, and the child got back 6/12 vision with this correction after 3 months. Now coming to the left eye, we found he had apical scarring, and the ASOCT revealed reverse donut sign as found in various very severe keratoconus. There is reverse epithelial thickening at the apex. As the pentacam revealed the thinnest packing to be 154 micron, we did not plan any active intervention. Only the parents were counseled regarding prevention of eye rubbing for the child. But this left eye also came with acute eye drops after about 1 year of right eye, and the parents were not at all ready for any further surgical intervention. So we had no other choice than to start topical steroid under cover of topical antibiotic for the left eye. And it luckily scarred well after 3 months. So post-scarring, we did the miniscleral lenses trial for him, and after 3 months, he got back 6/9 N8 vision in the left eye. So as this child was in amblyogenic age, we did not wait for the conservative management in the right eye, but had to in the left eye. So we should give broad spectrum antibiotic in case of conservative management, and along with the anti-glaucoma medication. The risk of infectious keratitis in these cases increases because there are some transudation of aqueous through the edematous cornea, even if there is no perforation. And poor hygiene is obviously a very important cause, which may be the main thing in our case. And this case report was published in IGO 2023. So if you want to read in details, you can see. Thank you so much for your patient hearing.
Great case, Sumana. I think, yeah, Prabhat is here.
So, Sumana ma'am, could you just, I think there was a little bit of a gap where we missed a little bit of the video. Could you just take a minute to just summarize your case, and then we can have a short panel discussion on the same?
Actually, can you hear me?
Yes, ma'am.
Actually, this kid presented with acute eye drops in the right eye. And as he is only 6 years old, we are at first at a loss to see such a severe complication. And the child actually doesn't go to school. That's why the parents were unaware that he had any visual discomfort. And that is the level of education, lack of education that has led to this problem, and they did not resort to any opinion before they had this visible scarring in the right eye. And so as we could not see most of the things in the video, we did, because we were waiting for the GF fitness for the child, we wanted to do pneumodesmatopexy for this complication. The child was put on topical steroid and he developed a pseudomonas ulcer in that eye. And for that, we had to do a optical penetrating keratoplasty later. And luckily, he got back good vision in that eye. But the left eye also had a similar fate. Luckily, we did not have any infection in that eye. And he also got back a good vision with a scleral contact lens. So the highlight of the case is that we have many weapons in our armamentarium in present era, so that if the patient comes with detrimental side effects also, we can give them, vision back to them. But it is very important to reinforce that they have to stop the vigorous eye rubbing, and the parents has to be educated that they need to show to an ophthalmologist as the case appears. Thank you.
Wonderful. Ma'am, any systemic associations could you identify in this case, or,
No.
did you...
Not really.
Okay, yeah. Okay. But, I would like to ask the panel if the severity and the early age of onset of VKC is related to increased likelihood of systemic allergies in their experience. Whether the younger the child, the more likely to have systemic allergy, or vice versa.
Yeah, I agree with you, Prabhat, completely. In fact, even that was the first question that I had asked Sumana as well. Usually, we don't see such severe cases at 6 years
Right.
of age, where they have already seen a pseudogerontoxin. Again, something, you usually have an onset of VKC also at around 6 to 8 years of age. And we always say that earlier onset will, you always have to look out for any systemic association like an atopic dermatitis or asthma or something. So, but that was something which was unusual in this case.
Yes, true.
To get an Pseudomonas ulcer on top of that was quite a
Yeah,
devastating.
that made the life complicated for the child and for me also. Luckily, he got back good vision. That's the best part.
Very well
But I'm
managed.
very happy that you could get a clear graft in a child with allergy, and maybe I don't know what is a follow-up you're talking about. But
It's almost 3 years, ma'am.
sorry?
He is doing well. 3 years, almost
So
3
then I
years.
really congratulate you for all that, because normally to maintain a clear graph with all these underlying conditions, I have
Yes.
problems. I don't know how others talk
And
about.
he is maintaining the scleral contact lens. That is also an achievement
Yes,
for
true, because that was my next question. With BKC even fitting the contact lens and scleral contact lens, they normally don't tolerate because they
Yeah,
have
but
those papillae and then they have the foreign body sensation, and they may be okay during the trial phase, but then later they come back and say that, we just don't tolerate those contact lenses.
absolutely. But the quality of vision has improved so much for
That
him
I agree. It
Yeah.
would. That it
that
would.
the child takes special interest in putting the lenses, and he insists that lenses has to be put in his eyes. So that's
And
a good
I've
thing.
usually seen that after when a hydrops resolves, the vision usually improves because
Yes.
the cone flattens and even fitting
Right.
the contact lens becomes easier.
Yeah, 100%, ma'am. Yes.
Prabhat, if you permit, can I ask one question to Dr. Swaminathan?
Yes, ma'am.
And Dr. Mitesh, if it's okay, just one question.
Yes,
Dr.
yes.
Swaminathan, have you noticed any difference when we talk about immunology or ocular immunology when we compare young and the older? Like, do the younger have a more aggressive immune mediators on their surface or as compared to adults, or it doesn't really matter?
I have not done head to head, ma'am. Usually the age matched age match is what we do. Now since you've mentioned this, I'll compare across the age. Pediatric.
Like, in rejections, we always say that the kids reject much faster than the adults. So that's how this
I
thought
see.
came to my mind.
I'll go look at the repository data which we have, the biomarker data also. Maybe I have to reanalyze it based on age. I'll do that. Thanks for that thought, ma'am. I'll do that.
Dr. Swaminathan, can I ask one question?
Yes, please.
You mentioned about epithelial barrier one medicine triholase 3%. Can you tell me something detail about it? What age, beyond what age we can use? What are the indications? Along with dual-acting antihistamine we can use or not? Whether it's with tacrolimus we can use or not? Any side effects? Preservatives are used or not? Because we
Yes,
are
I
not
can
aware
give.
of that medicine triholase. Because if you protect your epithelial barrier, as we are, everybody is try to avoid environmental control and allergen control. Talking about allergen control, so epithelial barrier is very important thing. So that medicine can do wonder in future.
Yes, sir. I borrowed it from our cornea refractive ocular surface consultants. It was not my creation, but of course we did extensively work in the lab with trehalose, and many of the drops, eye drops, lubricating drops, have started having trehalose as one of their. They call it the excipient. Initially, Thea, I think it's a French company, eye drop in Europe had this. Only trehalose. Trehalose is like a sugar, two molecules of glucose put together. It is coming from a plant source or a microbial source, and they are part of. If you do organ transplants, when you are having that media that has trehalose in it, all anti-VEGF injections or many of the formulations has got trehalose as a osmotic regulator inside. But what we have realized is that 1 to 3%, 3% more effectively induces a phenomenon called autophagy, that is inside the cell. Every cell has its own clearing mechanism for it to remain healthy. So trehalose induces the autophagy, that is the cell's own clearance capacity so that it resets it back to homeostasis. So that is the scientific basis behind it, and it reduces inflammation, it improves barrier function proteins. These we have seen in our lab, and also it is helpful in corneal ectasia like keratoconus as well. So it has multifunctional, most favorable properties. And say Soha liquid gel has it, Microlabs Trehalube has it. These are all sodium hyaluronate based eye drops, but they have in the bottle you can see Trehalose in it. Mankind has got one. There are many. His Highness is called Aquam Tea. So
you can
it
say
is
that we can
available
use
as a
in
regular lubricant.
perennial allergic conjunctivitis. Can we use it?
I think so. So I intentionally provocatively added. I provocatively added 3 components: Leafy grass because it's a T cell blocker which is used in dry eye. That can be considered because it does bring down T cell activation, and it is irrespective of Th1 or Th2. Number 2 was Trehalose because while you're managing with mast cell stabilizer and other things, you can also bring a soothing effect to the ocular surface, where Trehalose can be part of your tacrolimus formulation or not. And the third one was omega-3, systemic or topical. It does not matter because it brings back. So it was a intentional provocative thing I did, but I do not know. Only clinicians can bring more meaning to it. Yeah.
Thank you. Thank you.
Thank you, sir. Thank you, sir. So can we have the next case that has been prepared by Dr. Supriya Sharma? She's a cornea. She trained as a cornea fellow from LV Prasad Eye Institute and is now working as faculty in cornea and anterior segment at Shantilal Shangvi Eye Institute in Mumbai. Shweta ma'am, could you put up her video, please?
The outset, I would like to thank IIT, AIOS, and Dr. Shweta for this opportunity. I shall be presenting a case of VKC managed with topical and systemic therapy. A male who presented with severe redness, itching, watering, and sticky discharge in the eyes since 3 years, and drooping of the eyelids since 1 year. He was already on topical medications, and the medical records mentioned that multiple courses of topical steroids were prescribed in the past 3 years. However, he did not have any symptomatic relief. This was a clinical picture when the patient presented to us with the best corrected visual acuity of 20/100 in the right eye and 23/20 in the left eye. There was presence of diffuse congestion. The upper tarsal conjunctiva showed giant papillae, as can be seen here in both the eyes. There was presence of limbal thickening in both the eyes with Horner Trantas dots. Process of mixed form of VKC was made, and the patient was prescribed topical lubricants 2 hourly, sodium chromoglycate twice daily. Course of topical steroids was prescribed. That was started with 6 times daily and was then gradually tapered over the next few weeks. This was the clinical picture at 2 weeks, where there was symptomatic relief and the congestion over the upper tarsal as well as the bulbar conjunctival surface had settled down with resolution of the limbal thickening. Presented with an IOP of 28 and 32 and was a steroid responder, following which a quick taper of topical steroids was prescribed and topical anti-glaucoma medications were prescribed to control the intraocular pressure. The patient presented at 6 weeks with worsening of symptoms and increase in the congestion involving the tarsal as well as the bulbar conjunctiva. There was increase in the size of giant papillae with severe congestion, as we can see here in both the eyes. The limbal thickening had reappeared. For this visit, we realized that the patient definitely responded well to topical steroid, but that could not be continued as the patient was a steroid responder. Hence, we had to move on to the next step, and this is when the systemic therapy was introduced. The patient was prescribed oral steroids. It was started with 20 milligrams and then taper off to 5 milligram weekly. And systemic cyclosporine, 50 milligrams twice BD was introduced. Clinical picture at 4 months, where we see that the giant papillae have regressed. The surface inflammation is under control. The limbal thickening has resolved. There is minimal corneal scarring and vascularization, as can be seen here in both the eyes. The patient still has posterior subcapsular cataract and has not been operated for the same. To conclude, topical corticosteroids in VKC are reserved to control acute exacerbations of the disease, as long-term chronic use is associated with side effects like cataract and glaucoma. A subgroup of these patients are either refractory to steroids or are steroid dependent. That is, the disease flares up as soon as the steroids are tapered or stopped. In such cases, systemic immunosuppression plays significant role in controlling the disease. Oral cyclosporine is a calcineurin inhibitor that acts primarily by inhibiting the T-cell mediated inflammation and hence is preferred for long-term immunosuppression in cases with severe ocular allergy. There is enough literature to support that the structural regression of giant papillae peripheral limbal stem cell deficiency has been seen with use of oral cyclosporine. While topical corticosteroids can help control surface inflammation and lead to symptomatic improvement, this degree of resolution is typically not observed. This is attributed to the T-cell inhibition of oral corticosteroids, which not only arrests further inflammatory damage, but also promotes remodeling of the papillae and the panels. Thank you.
Excellent presentation, doctor. So my one question is, in this case, why
Yes.
with the topical steroid, calcineurin inhibitor tacrolimus was not started, rather waiting for 6 weeks to progress for the disease? You could have started this tacrolimus before. Just my query.
Yes, so when the patient actually presented to us, he was already on tacrolimus eye ointment, and usually this causes a lot of stinging and burning sensation, and that is why the patient compliance to this is also one major issue why why children specifically are not very compliant with use of tacrolimus. Those who are have shown excellent results, but this patient particularly was not taking tacrolimus routinely.
And what about topical cyclosporine?
So topical cyclosporin. So I always felt that considering the chronicity of the disease and considering that this was a school-going child and they require frequent medications, just adding one more topical medication would further compromise the compliance. So from whatever limited experience I have, I feel that systemic therapy in the form of either oral steroids or oral cyclosporin is the patients tend to be more compliant and have shown better results.
And this cyclosporin, usually we recommend taking blood pressure, urea, creatinine, and electrolytes.
Yes,
so is it
yes,
necessary to do?
Yes, we did a
Every monthly?
baseline and then we repeated at 6 months before starting therapy, and then we usually repeat it at 6 months.
Have you encountered any side effects in your practice or?
Not really, sir. Not with, I mean, systemic cyclosporin has worked really well in chronic recalcitrant cases, but I would like to hear from the panelists. I mean, I'm sure they would have much more experience with systemic therapy.
So anybody can take this.
I agree with Supriya. Very well managed case, Dr. Supriya. And like we said, so tacrolimus is supposedly a little more, 20 times more potent than cyclosporin. So if tacrolimus is not working, we really doubt that cyclosporin will work. A lot of time in these patients who are supposedly refractory to the topical medication, there is often sometimes a systemic component. So was this patient also referred to an allergist, and did we rule out any systemic component?
So Dr. Shweta, he did not have any. I did not refer him to a systemic to an allergic specialist, and also he did not have any atopic dermatitis or coexisting rhinitis. But like my experience is very limited in terms of referring these patients to an allergy specialist. Now after this meeting, I'm getting a little more insight into as to which patients really require referral.
So I'll share a very interesting story. I had a patient who I was, doing everything that we could, and I realized that often I would ask her about questioning about recurrent rhinitis or recurrent cold, but she would always refuse. And then I realized that when we referred her to the allergy specialist, she definitely had a component of allergic rhinitis, which they identified. The problem was when we have watering of the eyes, the watering of the nose usually accompanies. So it becomes difficult for the patient. So that was like a learning point for me, where I realized that, the patient did have a running nose, but because the eyes were watering, she felt that it's just a reflex to it. And, I missed it, she missed it. But that was the time when the allergist helped us identify, and just with an inhaler and a good control of the rhinitis, she was able to. But I agree with Dr. Supriya, oral cyclosporin does work wonders for patients with recalcitrant VKC. And we recommend it once the allergist also tells us that, no, there is nothing systemically, whatever you're seeing is only in the eye. Then we take the call and we start oral cyclosporin, like Dr. Supriya did, after she had done everything else that was done, from topical immunomodulators to, from dual acting to topical immunomodulators to the patient being a steroid responder.
So what we experience is when patient is having... Yes, sir.
So I just wanted to say that I think Dr. already mentioned about that allergies are usually systemic. And it is considered to be like the concept is atopic march or allergic march. The basis of this concept is that the allergic manifestations or the clinical presentation changes with the time. So it might be possible that in a typical atopic march, the skin manifestation could be the first one, especially in infancy or probably the toddler age group. And later on, the respiratory manifestation or the eye manifestation comes subsequently. But sometimes the other way around also happen. But whatsoever you say, that there is a organ crosstalk which always happen. And it is very important, as Dr. Shweta was mentioning, that sometimes it is possible. What is happening? That if a patient who is having skin manifestations presenting to a dermatologist, but a patient who is having GI manifestations presenting to gastroenterologist, patient who is having eye manifestations presenting to ophthalmologist, or similarly to pulmonologist, and there is no connect in between. But the disease is same. It is the different phases of the same disease which is happening. And if we can just connect these dots, then we can actually help to, you can say, like build up a story. And that story actually gives us more clues that, okay, what to stop and how to stop. So I am saying that, like, for example, there have been patients which are having some other like neuropsychiatric problems because of allergies. And many a time are presenting to our psychiatrist colleagues or probably developmental specialist colleagues. And then, so on one fine day, they are following there for, you can say, for autism and some other things for years together. And on one fine day, they came up with some history that, oh, they are having some allergies also. And then they are being referred to us. And then when we worked them up, we got their allergies controlled. Then the patients by themselves are coming up and saying that now my developmental issues, my autism and my all other things are now getting more controlled, more better, even with less therapies, with less medication. So that is why what I'm saying, that allergies are usually systemic. And if we can just, you can say, like as Dr. Shweta mentioned rightly, if the allergist is giving you that, okay, there is no systemic manifestation, now you go ahead, then it is fine. But it is always better to, you can say, like work in a team fashion, and we can probably, you can say, like consult with each other more frequently, then I think that will be more connecting the dots. So this is my opinion.
Thank you, sir. Can I ask a question to the panel? Where do you put something like sublingual immunotherapy versus what Dr. Supriya has done, systemic immunosuppression? So how do you put them together in the treatment flow chart, or does somebody do something or does somebody do something else?
So I would like to take this question. So we need to really understand that, let us go back to the pathophysiology. We need to really understand that the allergen is there. This allergen is entering inside the body, and then this allergen is stimulating a immunological pathway. Now, in this immunological pathway, at first step, second step, third step. So on the first step, there are certain interleukins which are released, which are called as IL-4, IL-5, IL-13. Then on the second step, IgE is released. On the third step, histamine is released, right? So whenever you are giving antihistaminic, you are acting on the third step. If you want to go one step back, then you are taking anti-IgE, that is probably omalizumab. right? If you want to go one step further back, then you are taking IL-4 blocker, IL-5 blocker, IL-13 blocker. That could be your mepolizumab, that could be your dupilumab. If you are going one step better before, then at that time you are taking allergen avoidance and you are shifting the immune pathway from Th2 to Th1, that is allergen immunotherapy. That means all these things are having their own respective roles and they can definitely be combined together because they are not replacement to each other. We need to really understand that whenever we are using all these pharmacotherapies, even biologics are also pharmacotherapy. So whenever you are using all these pharmacotherapies, so these pharmacotherapies are acting on the effect. They are not acting on the cause. The only thing which is acting on the cause is allergen immunotherapy. So in a given patient, I would like to start both if he qualifies for allergen immunotherapy at that particular time. But if the symptoms are more, if the symptoms are severe, then that is not the right time to start on allergen immunotherapy. We need to control the symptoms, whether it is asthma, whether it is eye condition, whatsoever it is. We need to control the symptoms, have good control the symptoms, and then it's allergen immunotherapy. For getting the good control, you might require some topical medications. In case of asthma, it could be inhaler. In case of your eye things, you might require some topical tacrolimus or whatsoever we has been discussed. Or we might require some systemic therapies. That could be your biologics, that could be other different thing. But definitely they can be combined in any different combination. There is no harm in doing that.
So let us say you started something like a cyclosporin with an oral steroid, then initially you ended up stopping the oral steroid after the taper got done, and then you also started the sublingual immunotherapy. So at one point you would then end up stopping the cyclosporin and then continuing the immunotherapy until 1.5 years or whatever the prescribed duration. Is that what you're saying, sir?
So immunotherapy is at least 3 years. At least 3 years, preferably 5 years. There is no immunotherapy before 3 years or less than 3 years. So it is at least 3 years. Why I am stressing on this? Because there are so many, you can say, like myths in which people usually start and thinking that it is only 6 months and 1 year. But I think we need to really understand that it is at least 3 years, preferably 5 years. So if we are talking about subcutaneous immunotherapy, then 3 years might be okay. But if you are talking about sublingual immunotherapy, it is always better to continue for 5 years.
Okay.
And usually immunotherapies, when they are started, then at that time the symptom score and the medication scores start reducing somewhere around 9 months to 12 months of age. So we usually say that by 1 year, if your symptom scores are not, if your medications are not reducing, then probably the right surgeon, you have not selected probably the right patient, or you have not selected the right route or right immunotherapy whatsoever. There is something which is wrong, which is happening. So by the end of 1 year of immunotherapy, the symptom score or the medication score should start reducing.
Thank you, sir.
Thank you, sir. Okay. Are there any more questions from the panel?
Any questions?
All right.
So can we conclude the session?
Yes, sir. Please go ahead.
So,
Yeah.
thank you, IAP Allergy chapter and Ophthalmology chapter, for excellent first session. Now 2 more days we are coming up with the same thing. So thank you everyone and good night.
We can just have a formal vote of thanks from Dr. Shweta, please.
Dr. Shweta, ma'am, please.
Thank you so much. First, I would like to thank Dr. Neeraj for actually initiating this webinar, and a huge thanks to Dr. Namrata for immediately accepting it and making it one. Some really interesting talks by Dr. Swaminathan and the allergist friends, Dr. Neeraj and Dr. Krishna Mohan. I think we all enjoyed. And some beautiful cases by Supriya and Sumana made the discussion for the day more interesting. And we had 2 awesome anchors, Prabhat and Mitesh, who made sure that in addition to the talks, we had some good discussion. So thank you so much. And I think we are closing for the day, but we have next 2 days coming up, tomorrow and day after. So 8 to 10. See you guys soon again tomorrow. Thank you so much.
Thank you. Good night. Good night, everyone. Good night, ma'am.
Thank you. Good night. Thank you.